whole healthcare industry is going to change dramatically in the next couple of years.
To chronic disease management and the preventative aspect of care.
AI can now understand the key clinical concepts of what's being verbalized in healthcare.
Welcome to Cherry Live. I'm Dr. Jordan Valrath, physician, entrepreneur, and Chief Medical Officer for Cherry Health. We're talking about Canadian healthcare. Join us as we speak to innovators, industry leaders, and people working to drive the health system forward. Today we're joined by Dr. Rithesh Ram, rural generalist with a PhD in epidemiology. He's the president of the section of rural medicine for the Alberta Medical Association, the director of the University of Calgary's longitudinal integrated clerkship program, and the president, physician, founder, and family man, and works at Riverside Medical in Drumheller, Alberta. Dr. Ram, thank you for joining us today.
Oh, absolutely, Jordan. How are things?
So far, so good. So good. So rural medicine, been quite hotly debated in the media recently as fallen apart and really be a difficult place to actually practice, chronically short of practitioners and supports. How are things? You clearly have been there for a while. You seem to be loving it. Obviously now with your role within the AMA, advocating on behalf of the rural family medicine physicians out there. Like, what's the state of the union currently like?
Well, we have been at the crux of what we call geographic narcissism for decades. So what that means for everybody who doesn't understand is out here, everything outside for Alberta would be outside of Edmonton and Calgary. There is very little, if any, understanding that there's actually physicians and medicine and real things happening out in rural Alberta. And we've been having that happen for decades. So for decades, we've kind of kept the patchwork together, kept our hospitals open, seen all our patients, made sure that we still have these economic pipelines of money flowing because we've still managed to stay out in rural Alberta. So the state of the union for rural is probably the same as it's been for many, many decades. And what hasn't changed is that we're also the kingmakers when it comes to any government. So government doesn't stay in power unless they have us. So now it's time, again, like all my predecessors, to say that rural medicine, rural generalists, we need to be at the focus. We need to be first. Right? We've been providing gold standard medical care and team-based care and all the wonderful words and acronyms and concepts that are now suddenly the city is thinking, wow, that would be nice. We should do that. And then we should do it and tell rural. Well, surprise, we've been doing it for a long time. So how about we just tell you how to do things for once and we'll go from there.
So do you think it's sort of similar right now in the city, how it was in the rural areas for a decade ago, just in terms of the availability of physicians and locum coverage and, all those things that we are currently describing as falling apart and the system crumbling?
Well, there's a nuance there. So definitely when it comes to the acute care facilities in the city, they have all those problems. But that is like most things, Jordan, there's so many variables into there. I mean, one of the big variables is the fact that the acute care facilities and the teaching hospitals have all been relying on the residents for a very long time. So now, suddenly, when residents are actually getting more focused in having more of a balance, not being just treated mishapenly in the hospitals and not having shift after shift after shift, suddenly the services are going, oh, you mean I don't have a whole bunch of residents that's going to help me do the job that I'm being paid 6 or 7 figures for? Well, now we're going to have to reduce service as a result of that. Now, when the public hears that, they're like, what? Right? So, no, I'm pretty sure we have physicians and you have trainees. The public doesn't understand that the trainees are such an integral part of how the hospital stays open, how beds stay open, how wards continue to stay open and services happen. The public has no idea about that. But that is a very big component as to why some of those teaching hospitals, why some of those services are reducing. Another big reason is that there's just a general change in work ethic, right? We have physicians that are coming out in the first 5 years of practice, and rather than the senior physicians in any of those departments going, well, you know what, I'm going to slow down as far as my night call goes. Now we have physicians in the first 5 years of practice that go, I'm not doing nights at all, and if you don't like it, I'm quitting. So this is the state. So it's not all that, we got here because the government did a whole bunch of bad things to us. We got here, a lot of it, because we got ourselves here. And nobody was really putting all the pieces together to realize that, variable X, Y, and Z, and if all those things happen, and we have this Swiss cheese model of everything falling down at the same time, that this is where we're going to be, but this is where we're at.
And then just given that the residents are basically supporting and running a lot of the functions that are out there, how did things go in terms of the CARMS match this year for the rural areas and the rural programs in the province?
So the CARMS match did go better than last year, but as everybody who's listening, or as you know, we really had nowhere else to go but better, right? So last year was pretty horrific, especially when it came
It was a little
to
rough.
family medicine and rural programs. Like it was very bad. They filled it in, kind of in the in the after the fact kind of what we call third match of how they just kind of filled the program. So they all did fill, right? So as far as the public can understand, there isn't going to be this decline of physician output. It's still going to remain stable even from last year. But this year they did quite well. There was still some empty spots as far as the very rural goes after the first match, but those again they're looking to be filled in the second match officially, and if not, they can always use the same mechanism they did last year to fill them.
Okay, so definitely we're on the upswing here. That's fantastic.
Yeah.
What drew you to rural in the first place, I guess? Sort of jumping back out and zooming out to the backstory. How'd you wind up in Drumheller running the clinic?
So I was born and raised in Camrose, Alberta, and neither of my parents were physicians. So when I left Camrose, Alberta, it was pretty much, for anyone that remembers the Looney Tunes commercials where you have the keg of Acme kind of powder that's behind you. I kind of put it there, lit a match, threw it behind me, and said, "No more rural, right? I'm going off to the city. I'm never coming back, and that's how it's going to be." So went off to Edmonton, did my electrical engineering degree. And to keep that story short, I just didn't see myself doing that as a career. There was too much golfing involved, and just not enough of the skills that I actually learned in my electrical engineering classes, which I did love dearly, and it's a great program at the U of A. But because of that, I actually went down and decided to do my PhD in epidemiology at the University of Calgary. And somewhere in my second year of that, I remember very distinctly that the professor kind of sat us down for 45 minutes and kind of gave us the lay of the land of what life was going to be like as a healthcare researcher, where you don't really have a salary. There's no jobs for you. You got to fight for your salary grants every summer and every October. I'm sitting there listening to this for 45 minutes, and I think, man, I left like a 5 or 6 figure engineering job for this. Like, I want to like what I'm doing, but I also want to be able to buy groceries and eventually have a house. So then a lot of the colleagues, about 25% of the class or so at that time, were physicians. So they said, well, hey, why don't you go and be a doctor, and then you can, buy groceries, buy a house, and do research on the side, and everything's going to work out well. And I thought, well, that sounds like a great way to do it. So then that's where that MD PhD kind of program, leaders in medicine program, UC came about, which is a fabulous program, and I highly recommend to everybody. So, but then through there, I thought, well, because I have that PhD in epidemiology, I should probably only do internal medicine. So that was going to be my focus, my life. Through there, I realized that my passion didn't lie there either. I want so much control over the destiny of my patients. I want to be able to help them the majority of the time, not just see a patient, deal with this very minutia of what they're coming to see me for, and then punt them off into the world of specialists and other investigations. So as a result of that, I ended up in the rural generalist out in Drumheller. Rural wasn't anywhere I said that I was going to be again. When I told my friends that I was going to be a rural generalist, they laughed for a good 2 months solid. They thought I was joking up until the day that I actually moved and landed in Drumheller. So in Drumheller, I really saw the passion of it. It really reinvigorated me into what medicine is, and that's rural. Rural is 100% the way to go.
And then how's the PhD in epidemiology served you so far? What's the actual overlap with what you're doing on the day to day?
On the day to day, it's there. It's just not as much as an RCT would be in that sense, but the patient flow, the QI, the quality initiative aspect of it. I would argue actually the entrepreneurial aspect is also where I get some of that PhD focus and knowledge from. But you might have heard we had that thing called it's called a pandemic, I think, for a few years. So I
What's
could tell
that?
you, I could tell you that during that time, that PhD in epidemiology came in very handy. So never expected to be able to have to use it in that way, but I actually was the senior director to our disaster management team and how that actually rolled out as far as the pandemic went. So that was a very interesting time in life. Where it was, as physicians, we talk about working 24/7, 365, but I was actually doing that for 3 months. So I actually that whole 3 month cycle of my life is a blur. every day. Like, I have no idea what days they were. I just know there was 3 months in there where I was doing pandemic epidemiology stuff, and that was it. So
What did you learn in terms of how to think? Because I know a lot of the university degrees is not just the content of what you're going through, but what did you learn about like how to think about public health and just approach bigger systems level things?
yeah, so that one, I don't know if it's where I was taught or whether it was more just the fact that by default I was what they call a mature student, and a lot of medical students will say that mature students based on age, but I mean I went through a lot of hardships, going through medical school and before. My father died at a young age because of medical complications and medical errors, actually, which really stuck with me going all the way through into medicine. So the how to think, and for anyone that's trying to go that way, is it's always the flip side. It's like, think of yourself sitting across the table and seeing what they're thinking and how they're looking at things. Think about what the real world complications of what we're kind of look at are. Like, what are the pragmatic ways of thinking about it? Because outside of the bubble of training, outside of the bubble of what an RCT is, outside of the bubble of the perfect experiment that you're going to do in your lab, there's life. And life has so many other variables. And to make all that work, that's how you're going to make all that successful for you. If you pretend that you're going to be in a bubble and on a petri dish forever, then you're not going to get anything.
Yeah, just always considering that other side's perspective and the opinion. I guess that comes into play with all these different facets of medicine or even just interacting with the patients.
Yeah, no, absolutely. If you don't have that, then that's where we can teach, and every school has it, right? We have these communications courses that we funnel all the medical students through. We teach them to fife, and we teach them to don't shake the hand, but don't shake it too hard. Never hug your patient. All these things that we kind of teach them through communications. But can you really teach someone to be a nice person, like a normal, regular human being? I don't know. I'm questioning that one. I'd much prefer the take on, why don't we just let the right people into medicine? We won't have to worry so much about the communications and the pragmatic stuff because they will come in with that skill, and we can teach them the clinical stuff, which they probably don't have.
This episode is sponsored by Empathia.ai. This AI charting assistant captures your patient encounter and creates a clinical note, saving doctors on average 2 hours per day in charting. Healthcare professionals are often bogged down by endless paperwork. Their goal is for physicians to spend less time charting. Find them at www.empathia.ai. That's EMPATHIA.ai. I bet. And then, so, you've done quite a few different things. Your name's on a lot of different parts of the system currently. One of those being the UCLIC, the Rural Students Program for the medical students coming through and training. How is that actually going?
Phenomenally well, especially this recent class, like the one that's heading out and got matched and going to residency. They're probably one of the most amazing groups of students that I've had the privilege of being a director for in a while. Like, very enlightened. They all obviously want to do, like, so many of them want to do rural, which is fabulous. Very engaged. They have a lot of that insight and judgment already, like just practical, like real life knowledge and know-how. So very excited about that. The actual UCLIC program is also going very well. We're looking at a major expansion over the next few years. I can lead this into the fact that I think everybody knows there's going to be the 2 new medical programs. So Lethbridge is going to be the southern program, then Grand Prairie Polytechnic is going to lead the northern program. Those are vital. So they're part of, I think, a cohort of about 9 new medical schools that are opening up over this kind of span of 5 or 6 years. Very important. Obviously we know that getting more physicians out into the workforce, that's one of the major steps. We can't continue to say that we're going to have increase in population and not actually increase the numbers of physicians. So those medical schools are going to be very important, but they're only going to be as important as they as they are innovative and as they do something different. We don't need another U of A and U of C that just happens to be located in Lethbridge and Grand Prairie. We need innovative schools that are going to let the right people into those schools. And by the right people, I mean the people that are going to feel that they have this social accountability, that they feel like they're going to go out and make that difference everywhere in the world, not just in the tiny box in the one corner of Calgary, Edmonton, and that's the only community they want to live at. It's the only community they want to practice at. And if they can't do that, well, then they're just not going to work as hard. Right? I don't need any more of those. I just don't. I don't need any more orthopedic surgeons that only want to work in Calgary and Edmonton. Give me orthopedic surgeons that want to use the OR time that is in all these rural areas, the ones that are going to move out and do all those things. We can create these very fabulous institutions of excellence in rural Alberta. We know that John Hopkins didn't just populate there, right? Because they thought, man, this is a great town we're going to be in. No, the town was there was nothing there. And then John Hopkins came and kind of built that, right? So we need that kind of focus. We don't need the let's just keep building up Edmonton and Calgary. Edmonton and Calgary are built. We need to actually diversify. We need to get these economic pipelines going, and medicine is a major way to do it.
How do you see the, and not just the education shift at these rural schools, but also like how do you screen properly for the people that actually are passionate about rural healthcare? You know, I imagine anybody's willing to say whatever it's going to take to get through their medical school interviews. Like, how do you actually sort the two out?
Yeah, no, very difficult, and you and I both know, right? You try to come up with the perfect system, and the very next iteration, students have gamed it so hard that they know exactly what to say and exactly what to
The
tell
cat
you.
and
So,
mouse game continues.
so
Yeah.
so it's always going to be a difficult challenge, but there has to be some belief in the person sitting across from you. So I know like the MMI, like you can't divert from the questions that are on your sheet when you're going through these interviews. You're not allowed to smile at them. You can't nod, right? You can't give any sense of where things are going and all that. We made that so impersonable because of the threat of students suing programs as to why they didn't get to med school. That's one of the major reasons that it's that way. It's not because we have data to back it up that this is more legit, it's better, it's less bias, and etc. But shouldn't we have a bit of bias? Shouldn't we actually have a different sort of process, whether it's random or not, to actually talk to the person, get the data out of them in a meaningful way? We can hire lawyers to do that, put them on the stand. I don't know, but like a meaningful way to get the actual truth out of them, as opposed to the rubric that we're trying to get and just kind of populate into them. I mean, you probably heard
They need a
Queens.
polygraph station as part of your
Yeah.
MMI, I guess.
So some schools have gone down. The scientific way of thinking about that one is some schools have gone down this emotional intelligence quotient kind of deal where they come up with different screening processes. A lot of that is done in the U.S. A lot of different screening processes to try to figure out how to tease out this kind of good human being aspect and who we want to be in a physician. Queens just announced in the last while that they've updated their application process to actually include a randomness into it. So I think at the very beginning, you have to meet certain criteria to get your application into the Queen's Medical School. I'm pretty sure it's Queen's. And then there's a random, literally what it sounds like. If you wrote everybody's name on a piece of paper, put it in a big hat, and then you pull out 600 people out of there or so. And then the 600 have to go through the kind of a more formal traditional screening process. But there's that randomness into there. I'll be very interested to see what that does. Because we all know, like the U of C, U of A, Queen's, there's almost 3,000 applicants to medicine in every school. Like we're not shy on people that want to do the work and want to do the job. What we're shy on is actually selecting the correct ones so that we don't need so many people. So we have the people that want to work and want to do the things that society needs.
Definitely. I mean, on the other side of things, I'm just like, what they tried looking at like mandating billing codes a few years ago and just like geographically restricting them. That didn't seem to be like a super popular idea. I don't know. Do you think there's any role for that, or is that just like we don't want to be prescriptive and forcing people down pathways they don't want to go, and then ideally we should just have that upfront selection interview be a little bit more real and personable?
I prefer the upfront. It goes back to that comment about can we teach people to be good people? Can we teach people to be nice? Can we teach people to communicate? Or are we're spending so much time on that aspect because we picked the wrong people to begin with, right? So I'm much more a fan of that part. It is much more challenging though, because that's like a whole bunch of light switches that you have to manipulate and change to do that, versus something like the billing code thing where you can say, you know what? Our community or this part of Alberta, wherever, needs these types of doctors. And if you want to come be that type of doctor, you have to go there. So that's a much easier thing to do, but I prefer the other way that's more sustainable. It's more sustainable to look at the initial process, get the right people into there, and then we never have to talk about forcing people to work in certain areas. Now, that aspect of, well, society spent 300 grand to get you trained as a physician. And that is all lost, right? The notion that medical students understand that or care about that is lost. So it's really hard to use that as the argument, even though it's the truth, right? It is the truth, but the flip side is society chose to do it that way. So now you're going to force me to do these things. Like, there's always going to be that disconnect. Versus if we just go back to the very start and say, if we can change the variable from 25% of medical students, usually the stat out there is that a quarter of medical students should never be doctors. The programs know this, the schools know that. They just don't
Based
know.
on they're just
They just don't know how
not
to tease
doing
that out.
well.
It's based on like professionalism stats that a lot of schools, a lot of places will have that, and then there's a lot of anecdotal evidence into there as well. So it actually could be higher. I'm just going to use 25%, but rather than focusing on the 25%, trying to make them into good, reasonable, hardworking physicians, why not just go back and say, can we make that 1%? How about we make it so that the other 24 are actually the reason we spend a lot of time and focus and get things going. Like, I think we should work that way.
What about like the middle ground option? So here in Alberta, we've got the rural, is it the RRNP? Is that what it was? Like the big chart, the list of the bonus, just the flat rate on top of your normal billings, depending on subjectively how rural you are in the location. Like, that seems like a pretty easy lever to pull and manipulate in terms of, why not just crank up the incentives the further you get, or lower them a little bit when it comes to being nearer to the urban centers? That seems like a pretty easy way to actually get people moving around. Just change the incentives.
Yeah, I agree. I mean, I'm all about. I use incentives not necessarily to drive change, but to remove obstacles to change. That's the way I look at incentives. So definitely, that's a program that's already available, right? The RNP has been there for quite a long time. It was stripped a little bit as far as there used to be retention compensation benefits as well within kind of that program, and that disappeared over the years. And obviously now we're looking at, why are we having so many issues with retention? That's one of the levers that definitely could be fixed and moved. So I completely agree with you. When we have programs like that are already in place, we just need to reach an incentive threshold where suddenly, instead of it not having a factor in retention or not having a factor in recruitment, we will get there. There's always a bar, right? We just got to reach the bar, and whatever that bar is, we just go a little bit above, and suddenly, oh, look, we're having improvement in our numbers.
And then on the flip side, when it comes to the actual facility at Lethbridge and in Grand Prairie, what would you like to see done differently compared to, the Calgary Edmonton program, or even, the Fort Mac, the Red Deer existing rural programs that we've got?
So I would like to see this one have more of that longitudinal focus onto it. Obviously, being the UCLIC director, I know a lot pedagogically. The longitudinal focus of how to train students is the way. It's the way now. It's the way going to the future. And all of the major medical programs in North America, so we're talking about the Harvards, the Princetons, the Yales, they've all included and changed into having longitudinal training involved. Some of them have done that from day one. Some of them have incorporated it kind of later into the clerkship, like the U of A and U of C did. But definitely, I want to see that aspect because it's more real. It gets students out into the communities more. It gets them away from the ivory towers. We can't have them sitting in these academic clinics pretending that this is what medicine is, because that's not medicine. That's not real. So that needs to be a very minor, if any, focus in those two programs. And what they need is to actually have the pragmatic, real sense of doctoring that needs to happen. I'm not just talking about primary care rural generalists. I'm talking about this includes any of the surgical specialties and kind of going forward. You asked what I think needs to be different. I think for those two programs, they need to be purpose driven. If we feel as a society that we need generalists in pediatrics, in primary care, general surgeons, anesthesia, then we need to make sure that those schools, that students that go to those schools know that when you're done, you're going to be doing one of these 6 or 7 programs. You don't get to go be an ophthalmologist. We don't need them. We have too many. You don't need to go be Another plastic surgeon that's just doing non-burn treatment victims. So people that aren't doing just skin cancer. We don't need more of those. We just don't. There's enough of them. We don't need more orthopedic surgeons that are just going to be doing a whole bunch of hips only in Edmonton and Calgary, because we have those. They're there. We need ones that want to go out to Medicine Hat, stay in Lethbridge, go out to some of the peripheries. So we need students to realize that these are the only things you're going to get to do. And if you yell and scream when you're in the medical school that you want to do something else, well, then you have to quit. We're not going to placate to you transferring to the U of C to get your ophthalmology rotation and your radiology rotation. We're just not going to do it. So those programs have to be purpose driven. They have to be selective that way. And like I said, we have 2,500 to 3,000 applicants to every medical school in the country. We're not shy of applicants. And so the school isn't suddenly going to go, oh man, we didn't fill. Like, that's not going to happen.
Then maybe they just need like how to tie a fly, onto your rod course, and how to go hunting, the fun parts of living outside of the city that everyone's missing out on.
Yeah. They used to have, like, McMaster always had very unique interview and application cycles. So they used to have some of those kind of stations, but I'm not up on that anymore. I don't know if they still have them. So.
And then, so when it comes to the clinic itself, so you've been successfully operating in Drumheller. How big's Drumheller in terms of population?
Drumheller has been a stagnant 8,000 for, I think last I checked, like 2 decades at least. So it spills over entirely when it comes to about this time of year until Thanksgiving, where on any given day there's 20 to 40,000 people here because of all the tourists that come in. But as far as Drumheller proper, it's about 8. Our catchment area for official patient population is about 36.
And like, just as an owner, operator, physician, how are you managing throughout all the difficulties and the challenges and the inflation, budget crisis, all the stuff? We keep seeing all the data on how many physicians and their practices are, 3 months away from going bankrupt and falling apart. Like, how are you guys managing? Does that seem accurate for, the community and all the rural practices that are out there?
It's definitely accurate for some. It's not accurate for us. So as an entrepreneur, as a small business owner, you have the ability to pivot when needed. So I don't know if you're a fan of Friends, but there's that episode about them pivoting with the couch, and
the couch
that's
in
not
the
really
stairwell.
Yeah.
Yeah.
And yeah,
Pivot.
As an owner, you can do that. So for me, when the pandemic was coming, and as an epidemiologist, I saw that coming just kind of days or weeks before. So I already knew that the way that we were delivering care to patients was not going to work if we couldn't see them. And also, if I couldn't see them, that means the main generating part of income for the business was also going to be in trouble. So we pivoted essentially overnight to be able to work within the fee code structure that was there at the time. This is before all the wonderful virtual codes and all that, to pivot into a structure whereby the actual operations and the business and the staff and et cetera could still function and move forward. So the headache of the pandemic causing us financial difficulties for us was short. It was very short, because as owners, we were able to pivot and make things a reality for us, for our patients, and then kind of going forward. So in the pandemic times where we had colleagues that were closing clinics, that were letting go of staff here and there, that we had orthopedic surgeons that were running around the emergency department begging to see patients because they had no OR time, right? We were flourishing, for lack of a better way of looking at it, because we pivoted. Our patients were all being seen, income was being generated, the operations flowed. So no issue. So every med student or every resident or anybody I say, no matter what discipline you go into, when it comes to medicine, at some point you need to consider and pull the trigger on owning your own clinic, becoming a small business owner, because then you can make changes that's going to ensure that you are financially successful. Now, of course, as you said, there are clinics out there that have owners that are struggling. And the unfortunate scenario there is that they accepted colleagues, like non-owners, into the group that just aren't pulling their weight, don't want to pay the overhead, don't understand the operations, don't understand that staff aren't free. That probably blows people's minds, right? But there are physicians out there that think, oh, but the staff, they're basically free. right? It's like when I was in residency and I have all these nurses around the hospital and everybody's just doing stuff for me and it's wonderful. And I didn't pay for any of that. Like physicians, like they lack that kind of reality and that's the unfortunate thing with some of my owner colleagues is that they've, unfortunately, that you need numbers, right? So you can't always wait for the perfect colleague, but you let too many of them in and it sinks you. And it's a major issue.
And so in terms of that recruiting, making sure that you've got a team that's bought in, the physicians, partners that are coming into it, the groups or, strength in numbers side of it, it sounds, just that economies of scale and having a bigger clinic seems to really help weather the storm. Are there any other like common themes you've seen for the clinics that are, not struggling or struggling less throughout everything?
A very common theme is having the right staff. So I've been asked numerous times if I would actually open up another Riverside Medical somewhere. So, and I've looked in St. Albert, I've looked in various places in Calgary and Edmonton, and in all of that, in the back of my mind, I know it's not that I need the right physicians to work at those; it's that I need the right staff. Staff are the major reason why we have a very successful practice, why we're able to have, you know, at least at a minimum 40 patient encounters a day. The average is probably more like 60, right? So our output is what we're producing as far as service and care to patients. That's not because I'm a crazy robot physician that's doing all this, because I have staff that has a ton of knowledge, that has a lot of buy-in to the patients as well. Like the staff they're part of the care team. And I'm not talking about just the ones that have specific healthcare background and knowledge. I'm talking about everybody that we have here, and that's the major thing. So that's what very common across all my other colleagues that didn't have many issues, at least as far as being an owner, is that you have the right staff. You have the right staff. To be honest, you have the right staff. You can tell the wrong physicians to take a hike. It just doesn't matter.
I can definitely echo that. Like that one clinic that I was locuming at specifically comes to mind, where it was just like a revolving door of staff. Like it seemed like almost every other week there'd be new MOAs or new nurses, and it's just like absolutely killed the flow of, there was no way to get in a groove of doing things. It was just very, very difficult, and having that consistent, well organized team just goes such a long way to being efficient.
Yeah. Oh, it's huge. It's massive. And, we lose sight of that. We lose sight of that through medical school and through everything else, that is such an important aspect. And don't get me wrong, I don't like HR. That's not my passion. So nobody wakes up dreaming of an HR problem they have to deal with, and I definitely don't. So it's just something that you just have to realize is part of the job. It's part of what it is to be a physician.
We were chatting a little bit before we started recording just about the business aspect of medicine in general. Why aren't we including more of that in the actual curriculum? How to run a practice? We get a little bit in terms of how to bill, but it's otherwise like pretty free for all, depending on who your preceptors are, of how to actually run a clinic. Should you run a clinic? Are you the person to be doing that? Or should you be one of the partner physicians? Like why has this never become more of a mainstay? Obviously physicians running their own practice has been the MO and how the system operates for decades now, but it's still just this giant blind spot.
Yeah, no, it's a really unfortunate one. And part of that is whenever programs have tried to introduce some of the very pragmatic, real aspects of medicine into the residency program curriculum, for example, the feedback that they get from a lot of them is, well, this wasn't as important. You shouldn't have done this for me. You should have scheduled me another ER shift. Or you should have scheduled me in the OR. Should have scheduled me more clinic time. That's way more important than trying to tell me what life is going to be like. I'll figure that out later. And they don't figure it out. They just don't. We see that, right? The majority of physicians have no idea. Like the stat about, especially in the fee-for-service world, the stat that physicians are just wasting, 20% of their earned income, their hard-earned income, and just not realizing, not getting it. That's probably too low for most people. Like that number is probably way more conservative than it should be. But the fact that it's 20% at all is horrific, right? If I think back to when I first started, that first day, I think I spent 6 hours looking at the schedule of medical benefits and just hoping that I wasn't somehow missing $5 here and like a consult here or something here. people need to do that, because there's no point complaining 5 or 10 years down the road that I don't make enough when you just spent 5 or 10 years like blatantly forgetting about things that you were actually earned, that you were actually supposed to get, and then wondering what happened and it's someone else's fault. Well, it's no one else's fault. That was your job, right? You need to sort that out and figure that out. I am not a proponent of the salary-based model. I think that kills entrepreneurial spirit. I think it reduces output. Like if I got paid the same amount to see 5 patients versus 20, well, God, I'm going to see 5, right? I'll have a very relaxed day. I'll have coffee breaks. I will go for a run in the middle of my day. I will do all sorts of other things because there is zero incentive for me to do more than that. And we see that. There's lots of research showing that happens in the salary model, but yet that is kind of the direction a lot of people are taking it. Does it work in certain specialized aspects? 100%. Do I have colleagues that work in very specific remote populations that there is no chance of them ever having the output to generate income, and therefore needs to be in a very specialized salaried or grant or a different system? 100%. But they're in the few and far between. They're not the staple. They're not the regular. So that's probably a lot of the reason why, even though BC has a new compensation model, they have seen zero increase in access, zero increase in actual patient attachment, like none. Like, how do you have almost 1,000 new physicians, or 700, I guess, is around that number, and yet there's no increased access, and patients are not getting, there's not more patient attachment? How is that possible? But you don't, and I'm sure if they had it, we would see that in the news, they'd be championing it everywhere, but we're not. All we're seeing is that they're paying physicians $150,000 more. They have a whole bunch more physicians, and they're basically just hoping that they're going to have more attachment access somewhere in the future. But you can't really take that to the bank. You can't tell the 2 million people that are waiting for a family physician, oh, don't worry, you will have one eventually. Oh, but when? I need my meds tomorrow. Oh, no. Eventually. So,
This is the RCT being run right now, I guess. Welcome to the experiment.
yeah, exactly.
What is the antidote to that then? Like, moving on, I guess, to the next chapter of your world is now you're in the section of family medicine for the Alberta Medical Association. And this is like probably one of the biggest or, main heading things that you guys have been working on recently, is the pay model and the longitudinal family practice model. What are your thoughts on how that's been proposed and how it's coming together, sort of that in between the salary and the fee for service?
So I might have you stitch that one back together, because it's the section of rural medicine. So you might want to re-ask that.
Oh, okay.
Otherwise, family medicine will get mad. So
I don't want to get in trouble. Thank you. Okay. Hold on. If I connect, yeah, okay, everything's still good. Okay, so what is the antidote to that then, right? So moving on, I guess, to the next chapter of your world is, now the president of the section of rural medicine with the Alberta Medical Association. This is probably one of the biggest projects, main headline things that people are all looking at and waiting for the results to come out. This LFP model, this is the hybrid between the salary and the fee for service. Is this going to work properly? Like, how they've got the incentives proposed? What are your thoughts on the direction this is playing out?
yeah, and of course, LFP was the moniker, was the acronym that came out of BC that kind of flowed across and back, like all the way to the East Coast and all the way back. Alberta, we're not going to attach to something that's made in BC, because we are made in Alberta proud. So for us, it's actually the PCCM, which is the primary care compensation model. I'm pretty sure those are the words that are attached to it. So the PCCM is what's being worked on, as you said, very ferociously. The final report was due into the minister just 16 days ago or 17 days ago. So there's going to be some more discussions and talk about it. But is it going to be the fix for urban? It definitely could be. The unfortunate part of the PCCM in the current iteration is that there is no specific focus on rural. And being the president of rural medicine, that means that I can't really endorse it until I have something that is going to be specific for rural. And so we'll cut that out for a second, but could it be something that physicians will be paid more in the city for? Yes. Can I promise the timeline on how that could improve the system or access or attachment? I can't. I honestly can't. I try, and I have reasonable poker face. So when I go into meetings, I definitely try to say that this is going to be the case, but I can't promise that. And the problem with the reason that I can't promise that is if a year and a half into BC's model, if they had proved that those things were improving, by all means, I will shout that from the top of whatever building you need me to. I just have no data to back that up. All I have is hope. All I have is hope that we're going to pay physicians more and somehow that's going to get better. Do I want physicians to get paid more? 100%. Otherwise, I should probably give up this job of being president of any section, right? 100%. I want them to be paid more. Do I think that's necessarily going to equate to the system improving? I don't know. But we only have so many levers to pull. We have only so many directions that we can maneuver and that we can negotiate with. That for the city, PCCM is there. For rural, I need something different. And I'm going to continue to advocate and have meetings about it until I get it.
And what would you do differently for rural then?
So rural, it's a complicated beast, right? So we are what I like to call the superheroes of medicine. We are the specialists of everything, right? So our breadth and depth is huge. We are specialists in the rural generalist side. We all do ER coverage. We have, GPAs that are there, people helping out in the operating room. We're dealing with internal medicine stuff. We deal with all the palliative chronic pain, mental health, addictions, obstetrics, every discipline. You can go down the list. Okay, fine. Maybe we don't do any specialized ophthalmology, but we don't do any specialized pathology. But if you go through the rest of the list, we touch on aspects of almost every other discipline, but we don't get any of that financial respect that way. We're kind of at the periphery, we kind of shout and, people maybe listen or maybe don't, a bunch of echoes in the room. So until I have an incentivized model that works with how we work, then it's not going to go anywhere. And I don't think that's a salary-based model unless it's like an incentivized compensation where we still have access and incentive to work built into it. So there can definitely be a base, right? Every physician gets X dollars, and then great. And this is how you take care of your community. This is how you take care of your patients. But if you keep stepping up what you're doing, so if we take a physician that's doing GPA work because they're keeping the operating room working, and they're also not only in the rural area, but they're being asked by Lethbridge, or being asked by Edmonton or Calgary, please come help us in the operating room. Their patient panel, their patients are losing out on the fact that they have to go and help out in these areas. But they're doing it because they're physicians, they want to work, they want to help the system. They're getting lost in the PCCM work. They're getting lost in any compensation stuff, but they're doing vital work to the system, their community, and they're still coming back to their towns and taking care of their patients in the primary care and in the rural hospitals, right? So they're being lost in all that. So there needs to be some of that incentive built in. Now, there was all that talk about this last transitional funding model that went out, and there's a lot of angst about it because of the way that panels were created and such. I'm one of those, right? So the way that they calculated the panels meant that I should probably slash my panel by half because apparently I'm just seeing, ghosts and pretend patients for the other time. But so there needs to be the whole notion of panel. It upsets me in a lot of different ways, but I can go into that if you want, but that might lead into a whole other tangent. So.
Are any of the provinces doing this in a pretty good way? Who do you look up to in terms of how you'd role model Alberta's system off of?
Nobody. I think
start fresh.
Yeah, I'm not saying we don't have to completely reinvent the wheel, but we don't have to go down the direction of the things that haven't been working as well as they thought. And so there's a whole bunch of things that have happened in Ontario, BC, other places that we don't need to, if they haven't gotten the data to support what the outcomes are supposed to be, then why try? We're not different in that way, right? So we need to come up with different incentivized models that are going to potentially work in the way physicians are working. So for example, if we had in rural Alberta, if we had a fee code that physicians could use for our staff to deal with patient concerns and things without us having to visualize and see the same stuff that our staff is very engaged in doing, but we can bill for that. And that would help us with the overhead of that staff. It still means other patients are being seen because I'm seeing another patient instead of that one. It would increase that access, but it would allow for us to actually generate that income that's going to pay for that staff, pay for the operations. Then that's a very easy win, right? Then that's just one. So there's easy things to do in that manner. It's going to take a bit more leadership to get it through.
Perhaps it's better to view these things these other provinces have done, like BC, for example, with the pay raise, more of like the stabilization side of things. Because you make a good point, right? Of just paying people more money. Is that actually going to improve the efficiency and the number of people being seen and that access to care, right? I'm just thinking of like a computer chip as an analogy, right? Overclocking your CPU and just feeding in more volts, and then it does calculations faster. But when it comes to physicians and making the incentives actually align, maybe cranking up the actual fee for service model would be the incentive to make people actually start seeing more patients and actually improving that access to care.
Yeah, it would in one aspect. And this is where the hard and true academics and leadership that isn't necessarily out there in the trenches doing the walk-ins on the same days and all those kind of things go, we can't do that, because then there'd just be a whole bunch of corporate walk-in clinics that would populate the superstores and the Loblaws. And yeah, they'd be seeing more patients, but they're just not doing good medicine, right? And doing a lot of this like hands folded, nodding thing. There comes a point in time where the public goes, I don't care. I need to be seen outside of the emergency room. Like they're the public is going to come to a point where they're craving service so much that it won't matter that it's this non-longitudinal, non-comprehensive service delivery model. They just won't care. So if we spend so much time trying to build a system where we're talking about these teams and we're talking about comprehensive care, we're talking about longitudinal, if we spend so much of our energy just fixated on that, the public is going to pivot and say, that's great. You got that for 40%, 50%, 60% of the population. I'm part of that other 40%, and I just need to be seen somewhere other than the emergency room. Send me somewhere. And that potentially is what's going to shift things. So yeah, do we need a better incentivized fee for service model whereby we can just have output? We do. I'm not part of the group that says one model is best for everybody. I think just like in any small business or operations or any other service delivery, you can have multiple different ways of running a business, multiple different ways of being serviced. And I think that needs to be available, and then people can pick the ones that work best for how they want to work and how they want to see.
That does make sense. That does make sense. Now that you're with the AMA, now that you're actually like on the inside of the system itself, what have you learned about just how our system works? Is this what you expected? Is it quite a bit different from what you expected?
I'd love to say that it was exactly what I expected, but I like most of us, I was part of the physician group that thought, oh, so they just announced that good faith claims are going to be coming back. And when I heard that, I was like, oh, I can use that tomorrow. It should just like, there's just a simple click somewhere that someone needs to do. And one of the biggest eye openers for me was because Alberta Health, the actual computer system, like the servers, because that program and that system is so antiquated, something as ridiculous as turning on good faith claims again with a few minor, like back in my engineering days, I'd be like, well, that's just 3 lines of code, like ding, 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 off you go. Because this, like the actual hardware software system is so antiquated, every change that you make takes forever, like just forever, like that process to do something so simple. And that was pretty mind-blowing for me. It's like, so I always realize in the background there's a lot of red tape they have to go through and operations and et cetera, but I never expected that the actual computer system hardware program was just so antiquated that was such an issue to get things going. Like I never imagined that would be such a delay, but it is. And so that was a bit of an eye opener for me. I realize it now, so now I can understand that. But yeah, that was definitely something I wasn't expecting.
Just the legacy systems. We actually had one of our business mentors here at Cherry when we were first getting going. This was like 3-4 years ago. He was telling us he was actually part of the team that built that computer system. He was like one of the people helping to architect how it worked. And he was telling us that this is still how Alberta Health Services operates the billing for the whole province. And it was kind of, I didn't really know what to make of that at the time, what that actually meant. But like, yeah, we've got like a 40-year-old computer program, I'm sure there's been some turnover in the code. It's probably not 100% 80s code anymore, but yeah, that's like the backbone of how everybody gets paid in this province is 45-year-old computer software.
Yeah, and it's crazy, right? Because on a operational standpoint, you can think, so if we all go back in the day to Y2K, and we think, wow, like that was going to be such a turning point in human history, depending on which side of the fence you were for Y2K. But the amount of work that went in to fix all of those systems and the time and everything that went into it is so significant. And you got to think, we can't run this way forever. Like they need to I'm gonna say upgrade, and I have no idea what that means for the system, but they need to upgrade it in such a way where it's not this big of an issue. But I can't honestly think of what the stopgap would be, because you can't just turn it off. Because you can guarantee if they turned it off and tried to build a new one for even a week, that would cause a ridiculous amount of chaos within the physician world. Like even I would be up there like, what is happening, right? So there has to be some transition. I just don't know what that would be for a system that's so complicated and antiquated the way it is.
We'll find out in 20 or 30 years from now, I guess.
Yeah, exactly. When I'm maybe getting halfway through the career, retirement, or whatever that looks like.
So we got a few minutes left here before we got to wrap up. What else is on the agenda for your term as section of rural medicine?
So a lot of education for what rural means. I want rural generalists to be the term that everybody kind of hears when it comes to the rural side of medicine. I don't want anyone telling me I'm a family physician anymore. To be quite frank, I want everyone to say that rural generalist is his own specialty and moving forward. Again, want to see those two schools be as successful as they can be to meet the mandates that they're supposed to be mandating. Like I said, another U of C where the school was built on having half of its people going into family physicians. That's never happened. So I don't need Lethbridge and Grand Prairie to fall into that same unfortunate circumstance and situation. And it just needs the leadership to get it there. So as far as anything else, those are the main ones. And I think that's probably going to take up my entire time. We'll get financial respect for rural. We'll get it no matter what. I promised everybody that's the reason for me being here. And if I don't get it within a certain period of time, I might as well, not be here. So that's what we're going to do.
Okay, well, sounds good. And then we end every episode. What is your, it's kind of self-explanatory while you're walking on your under deck treadmill there, but what would your number one wellness tip be, I guess, for the people out there listening? How do you actually keep yourself functioning, keep your head level?
Can I give you two? So the two that I tell everybody, tell everybody is that get in your steps, right? These walking pads or treadmills, they're excellent. You can do it everywhere. I do it in between patients. The second thing is, just like we tell all of our patients with healthy lifestyle, there's input in and input out. So make sure you're actually tracking the input in, so the calories in. Lots of wonderful apps to be able to do that for you. And it'll be shocking to everybody how the calories add up when you're tracking it versus just, no, that wasn't so bad in my mind. I'll add it up. I can do math, right? But you put it on an app, huge.
Yeah, well, thank you. It's infectious. You've already guilted me into using my standing desk. I think this is the first ever stood up podcast we've recorded. So thank you for being here today.
Oh, absolutely. Thanks, Jordan. Anytime.